regarding obliterative otosclerosis, actually that obliterative otosclerosis or the surgery of obliterative otosclerosis, according to me, is a entirely different ball game. See, what happens is generally in otosclerosis, you have a focus in the non-obliterative types. You have a focus somewhere, usually anteriorly, sometimes posteriorly, sometimes here and there, wherever. But essentially, the foot plate where you want to make the fenestra or where the fenestra should be made, essentially that, histologically speaking, is the normal foot plate. Sure, it is fixed by an otosclerotic focus somewhere else, but the area in which you are going to make the fenestra, and the fenestra, I am going to term it as a surgical trauma in this case, which will eventually heal, because that is what is the actually the success of a stepidotomy. Once the piston is put, the way it heals, that is the success or the response of the body to the surgical trauma of the fenestration and its healing. But this, in a usual stepidotomy, in a non-obliterative case, the fenestra is made essentially in a area of the foot plate which is histologically normal. Now, in obliterative otosclerosis, what happens is the entire foot plate itself undergoes, and the surrounding undergoes a otosclerotic change. So now there is no histological normal foot plate present. In fact, that vanishes and the entire thing is now an otosclerotic bone. So the histologically the foot plate is not there. So the fenestra you make is actually inside a otosclerotic bone. It's inside the otosclerotic lesion, and therefore logically the healing of this is going to be very, very different from the healing that takes place when you make a fenestra in the normal foot plate, a normal fixed foot plate. This is very important to understand, and this is the reason why the so-called failures, reclosures, and things going wrong with the conductive loss, post-operative, these are the things which occur in an obliterative otosclerosis, because fundamentally the fenestra is made in an otosclerotic focus. So the trick here is to actually saucerize. The other point about obliterative otosclerosis, you have the level of the foot plate. Most often, the obliterative otosclerosis, the thickening of the foot plate is more towards the middle side, and very little towards the vestibular side. But sure, there can be vestibular, in patients of conductive loss, there can still be some amount of the obliteration which has happened on the vestibular side in the inside here. If it's too much, then there are some enzymatic activities and the cochlea and the other things can get damaged and you can get a sensorineural loss. But I'm talking about obliterative otosclerosis with conductive loss or maybe some amount of a mixed loss. This is important. So this thickness is what is the entire thing is the obliterative. The trick here is to try and make the maximum surface of the foot plate, drill it away and bring it down to the what you believe would be the level of the normal foot plate here. The trick for that is usually the anterior crus is difficult to either assess, access or even visualize, and the anterior crura tends to be more engulfed in the otosclerotic focus, but the posterior crura, especially the posterior part, posterior to the posterior crura, you can go on drilling and see the way the posterior arch curves down, and you can approximately see, if you notice the way the posterior crura curves and gets attached to the foot plate, which I used to call the crura foot plate junction. If you see that, you'll be able to tell this is now approximately where the normal foot plate may have been. Up to this point, you have to drill in the usual way, and beyond this, you have to drill like as if you're drilling a normal foot plate. This is where the change of color will come in and you will start being more gentle. And while you're drilling, you will keep on using, I use gel foam soaked in DEXA to make sure that the heat of the burr does not damage the vestibule inside, and we do not inadvertently induce, because sometimes the foot plate recorded is up to 2.5 millimeters thick, and the way to assess the thickness of the foot plate while you're drilling is to use the 0.8 millimeter diamond burr is typically what you will tend to use, or more, and the ball of that is how many multiple times is the ball going. So we use the ball of the burr as the measuring device. 0.8, 1.6, 2.4, that's the multiplication, is how you go on drilling the foot plate. Maximum surface, not just saucerization, not just around where you're going to make the fenestra, but maximum from the anterior crura to the posterior crura. If that's what you go on drilling, the chances of you having a reclosure of the fenestra go down significantly. The other important factor is obliterative otosclerosis is almost never present when you have a unilateral conductive loss. If the patient has a unilateral conductive loss, you can assume that this case is not likely to have an obliterative otosclerosis. This is, I think, again an important tip. Of course, CT scans have made a big difference, but the truth and the honesty is, in private practice, when I'm not still using the CT scan on a routine basis in the OPD, once you see or diagnose a case of otosclerosis, it's very good. One should go into doing the CT scans, but that is not the if you have the vestibular side. It's important to realize that the obliterative otosclerosis, the foot plate is completely replaced by otosclerotic focus, and that your fenestra is in an otosclerotic lesion, unlike the one which you make inside a foot plate which has anterior focus. And I think this is important. Regarding the measuring of the piston length, also, like I told you, when you start entirely thinning out the foot plate from the anterior crust to the posterior crust, the measurement of the piston length becomes exactly the same as you would do it in other cases. So you can't go wrong there, because one can fall short. For sure, I mean, it's known, I think it's juvenile or kindergarten to say that you should never drill a hole inside and try to fit, because that's the worst thing to do in an obliterative otosclerosis, because the free movement of the incus or the shaft of the incus gets impaired, and at some point you will get a necrosis of the incus. The free movement of the piston, I mean, gets impaired, and you can get necrosis of the incus. So obliterative otosclerosis, surgically speaking, is a completely different entity, because my definition of surgery is not what the surgeon does, but what the body does 100 days, up to 100 days after the surgery. That healing of post-operative 3 months is my final outcome. My judgment of my surgery is on 100 days post-op. So this is how we sort of push our bar of excellence. This is about obliterative otosclerosis. Yeah. So distinctly, when we look at a fixed foot plate, we have to consider several other differences. So when you have an anterior focus and a histological normal foot plate where the fenestra will be, this is completely different from a completely obliterative otosclerosis. Also, I'm going to bring in the foot plate fixation which comes from tympanosclerosis. In this, there is an external deposition which solidifies. So theoretically, it is not that the foot plate has undergone a change. Sure, the tympanosclerotic material, because of its proteolytic and enzymatic activities, can have certain resorption of the foot plate, but there is no transformation of the foot plate, which essentially what happens in an obliterative otosclerosis. And the other one is the congenital fixation of the foot plate. Generally, we are not trained to see this congenital fixation. Also, I am going to allude to the persistent stapedial artery. I am not very sure whether you have an otosclerotic focus along with a persistent stapedial artery that causes the conductive loss, or primarily it is the persistent stapedial artery which causes the conductive loss. because we haven't trained our eyes to look for the otosclerotic focus. And this also comes in very, in my mind, very important where the perilimb gushers are concerned. According to me, the perilimb gushers are more in the congenital fixation of the foot plate rather than in otosclerosis. And therefore, it is in much younger age group. If I don't see an obvious otosclerotic focus, these are the cases that I'll be very careful. If the age is younger, so I will talk about the perilimb gusher at a later point. But this point about persistent stapedial artery causing the fixation is also important. And also it is very important to know that because the artery is always anteriorly, you almost always have enough space in the posterior half to make this thing. It's very important to note that having a persistent stapedial artery is no indication to simply abandon the procedure. One can always have enough of a normal foot plate there. So obliterative otosclerosis, the regular otosclerosis with anterior focus, fixation of the foot plate because of tympanosclerosis, congenital fixation. The congenital fixation of the stapes foot plate is an embryological accident that happens typically in the second or the third week. And there's a fantastic work done by a French embryologist. It's amazing how the orchestra of gene expression alters all this, and most often it is the abnormality of the formation or the quality of the annular ligament. Now, annular ligament is an independent structure, and that is very important for the movement of the stapes foot plate. If there's something that goes wrong in the formation of the annular ligament, and the annular ligament is not even all around, there are enough studies made to tell you the dimensions of the annular ligament. If things go wrong here, you get a congenital fixation of stapes, and in those cases, the possibility, because it is an embryonic accident, the possibilities of things going wrong maybe in the cochlear aqueduct are also very high. But more importantly, it is the fundus of the interauditory canal which is really the dangerous gusher, as we call. The cochlear aqueduct can be ablated. There are reports that for a bad fundus from where the CSF leak, the gusher is coming, there have been times when people have had to pack the entire vestibule to stop the gusher. But these are congenital malformations. These have got nothing to do with otosclerosis. So you have to train your eyes to look for the otosclerotic focus, and it's very easily possible to see from its discoloration. So just a fixed foot plate does not mean your diagnosis is otosclerosis. Otosclerosis is a disease, and so are these other conditions independent of that. This is something which I would like to bring in along with the obliterative otosclerosis to bring in. I'll speak a little bit about the perilimb gusher, make some comments I think some other time with the details of how this embryological accident takes place and what all goes along with it. Scientists today are able to manipulate the genes to create all kinds of ossicular malformations. They can decide they don't want the lenticular process, they can decide they want to malform in animal studies. That much ahead embryology and genetic science has gone. And we can all bring all of that into our atresia surgery, but also in the otosclerosis surgery.